This is Chris Kell with our comprehensive client assessment evaluation, and that sounds really, really complicated. But really, when we're looking at assessment, this is our next piece on movement screening, and just looking at, how clients are in the type of condition that clients are in. All right, we talked about our goal setting module and kind of how that shakes out. Now we're just going to look at where we start a client. Okay, what are their movement challenges? Are they a beginner? What is their status? Do they have a base level of strength? What have they done before? Can we aggressively strengthen them, or do we need to work a little bit more on just some foundational stuff and just helping them to move better? So when we look at movement screening, this is sort of my poster child for movement screening. All right, this person's name is Caroline. Caroline has lost over 150 pounds doing 5 and 10Ks. All right, and she looks like somebody that is, pretty fit. And for her, we have an individual here whose body has changed, a lot in about 2 years. Her center of gravity has changed. She's put a lot more stress on her body now because she's, training for these higher level things. And she came to me when she started training for her first half. And so she'd only previously done 5 and 10Ks. She probably added 50% volume to her training that week. And so for me, one of the first screens that we did was the overhead squat. And what I did is I just looked at, I could see that almost immediately she started to squat down, she came forward onto her toes. All right, and that's a tell for lack of ankle mobility. All right, that allowed me to kind of break that out and look at, the situation with her ankles and see that, these are the primary factor that is maybe limiting her ability to run without knee pain. All right, her primary complaint coming in, left-sided knee pain. The other thing we saw with her, left weight shift a little bit more. So, left-sided knee pain. She commented that her knees would burn during the night, when she got home. So what I did was I just said, all right, here's what I want you to do. I want you to roll your foot with a ball. I want you to roll your calf. I taught her how to do a basic ankle dorsiflexion mobilization. And again, we'll get more into that stuff in our next presentation. But I said, all right, so I don't want you to run for 6 days. Come back and see me on the 7th day. Tell me how you feel. All right, run on the 6th day and then come back and see me. So she did. She took my advice. She followed the program. She did that every day. And she came back and she said, my knees didn't hurt after I ran. I felt, I felt better. I felt there was more spring in my step. And so again, for her, it's just the idea that simple intervention that we can make within our scope of practice is going to make a big difference for our client. The other thing with her is, like, in looking at her screen, it told me that I needed to prioritize with her training program a lot more hip dominant work. Okay, here we have somebody that lacks ankle dorsiflexion, that's in an anterior weight shift. The other thing that we found, very quad dominant. When she was doing things like her glute bridges, she felt it in her quads. And so for her, we did a lot of hip dominant work in the beginning, taught her to deadlift, taught her to shift her center of gravity back more, right, and just built sort of a more symmetrical frame between the posterior part of her body and the anterior part of her body. And again, for her, we gave her a lot more stability to balance herself out, and I'm happy to say, she ran her first half and she did pretty well, and she's training for her first full now. So again, it's not rocket science, but this process gives us a good idea of kind of where we start to make our interventions, how it drives program design, as well as, what not to do. That's going to be a big factor as well. How you doing, man? So the first step when we're looking at our movement screen is just posture. All right, posture is really the central conversation with everything that we do. And again, static posture is the beginning of any assessment. I tell people every movement the client makes, every time we see them is an assessment. And again, we're not going to normally take posture photos of clients when we're doing an assessment for our small groups or for our boot camps. Sometimes personal training clients or athletes, we will. But the point is that posture gives us an idea of how the client holds himself in space. All right, what do they do throughout the day? Kind of what are the positions that they adopt? That tells us, what areas are going to be most exposed to repetitive stress. For example, does the person stand in their left hip all the time, and as a result, maybe their left hip has developed some overuse issues, or knee pain on that side, or different things. If the client has a kyphosis, they have neck pain, that kind of thing, and they're on their phone all the time, again, it starts to give us an idea. So we can look at these postural things and start to correlate them to our movement screen. And so when we talk about posture and, the way we want to look at our movement screening is, we want to get as symmetrical as we possibly can, right? And the idea that every person is going to be symmetrical is a myth. Everybody is going to be different. We've all had different things happen to us, and so everybody's going to present a little bit differently. But the point being is that we want things to be as symmetrical as possible, and these alignment points kind of start to give us an idea of if, the person loses that symmetry in a certain area, we can start to expect, maybe some dysfunction in that particular area. So, we see the grid lines at the shoulders, at the hip bones, at the knees, and the malleoli down at the ankles. And again, it's the same thing on the back side, the scapulae, the back of the shoulders, the hips, the back of the knees, and the feet, and then from the side. What I like to do is watch a movement screen, or I always want to watch my screens from the front, from the side, from the back, so I can see, is there a weight shift? Is one side, do I see something on the front side that is then going to be correlated on the back side? And just being a good observer, of how somebody moves and orients themselves. So one thing that you can do is watch somebody just with their arms down and their arms up. And if we're looking at, if we were doing static posture with somebody, having them just pose with their arms down and then holding their arms overhead, we start to get a good idea of, okay, how do we see symmetry in their shoulders, in their ribs, in their hips, or do we see sort of this shift to one side? Is one side higher than the other? In this particular individual, you can see he has a bit of a rib flare, which means that his ribs are what are called anteriorly rotated. The other thing is, looking at them from the side, what does the spinal curve look like? Is it, does the person have an excess lordosis or an excess kyphosis, or do they look sort of just gradual? The other thing is when we raise our arms over our head, now we're having to extend the thoracic spine and we're getting shoulder mobility into play. So does the person have to arch their back to get there? Oftentimes when we lack shoulder mobility, the person is going to have to arch their back to get their arms over their head, and that starts to give us an idea. And then again, on the back side, we can kind of confirm, what we see on the front side. If the person does have their shirt off, we can see whether or not, the scapulae are, pinned against the body, or if we see sort of an excess, out curving on one side versus the other. So some things to look for in particular with movement screening are the position of the person's pelvis. All right, if we have this person with an optimal alignment, you can see that they do have a gradual lordosis of their lumbar spine, and that's normal, but it's a soft, sort of gentle lordosis, whereas we have a soft, kind of gentle kyphosis of the middle back, which is normal, and then we have a soft, gentle cervical lordosis, and so these are normal. Everybody's going to have that. But then with an anterior pelvic tilt, we have this sort of large divot in the low back, a more abrupt tilt, which is much more overemphasized, and that's what you'll oftentimes see is just sort of an over-exaggerated version of normal. So we see this divot in one segment where, often this person is going to feel maybe more pressure in that position or in that segment of their back because it's bearing the most stress. Whereas with sway back, this person still has a bit of lordosis, but a much more accentuated kyphosis as well. So, it can manifest itself in a variety of ways. And, you don't have to, I don't want you to think too much about it. Just score the screen. But the point is that with this, you can start to get an idea of how these things orient. When we're looking at upper extremity postures, you can see this person here with a protracted right shoulder. So the right shoulder is forward and down, whereas on the back side, the scapulae or wing bones are abducted. Okay, but this is an interesting example because let's say this is a pitcher. Okay, somebody that throws thousands of times a year. All right, he puts himself into this position a lot. So this is the body's adaptation to this position. That's what is called a functional change. Okay, and with that, we don't want to, if I took that away from him, if I made him completely symmetrical through whatever means, I'm going to take away a lot of his gifts, all right, his ability to be the freakish athlete that he probably is. And so for him, I just want to do what I can to manage that adaptation. Maybe I'm working on scapular stability on that side. I'm making sure that I don't lose total range of motion in my shoulders, meaning his motion in his right shoulder and his left shoulder are even though he might have a little bit more internal rotation and a little bit less external rotation in one versus the other. The total motion in each side, if you measure them, is still going to be the same. Whereas, with somebody with a thoracic kyphosis, you oftentimes see that. We see associated patterns. So this person has, a forward head posture that goes along with his kyphosis. And I guess the takeaway here is look at who you're dealing with. Athletes that, play a certain sport, the corrective exercise with them or what we do with them is going to need to be mediated by the patterns of their activity, the injury patterns of their sport, whereas with couch potatoes, if they're not doing things that are high intensity, they're not getting fatigued or they're not trying to perform in conditions of fatigue, oftentimes, the corrective exercise piece of things is not going to be nearly as important because they're never getting themselves over a threshold of injury. With them, it's more important to modify certain exercises in their training program to make sure that they don't hurt themselves, but important in either case. So when we look at movement screening specifically, the idea is the primary mechanism of injury behind most non-contact related things is repetitive stress versus traumatic injury. Okay, and so what that means is that certainly people will break their back doing a heavy back squat or getting hit by a car or that kind of thing. But when somebody tears their ACL non-contact or maybe does tweak their back when they're squatting, oftentimes it's not going to be due to the fact that that acute event caused it, but it was just sort of the last straw. So the person, the repetitive stress in that area might have been building up for a long time, and it's kind of the idea of maybe somebody tweaks their hip running on their left side, and so they start to shift their weight to their right side as a result. And over time, because they shift their weight to their right side, they start to develop more repetitive stress injuries on the other side due to the fact that I'm shifting away from the formerly injured side. So movement screening allows me to see that, and a big point that I just talked about would be that when we're dealing with people who take themselves or who play a sport or perform in conditions of fatigue, it's going to be much more important, because with that, there oftentimes injuries occur in the last 10 minutes of a soccer game, the fourth quarter of a football game, that kind of thing. So if you have an individual or an athlete who is frequently performing in these conditions, they no longer have any room to compensate as they become fatigued. So the stuff that we do with them is going to become much more important. Whereas when we're dealing with a couch potato, not quite as much. The other thing is that asymmetry from side to side is another cause of injury or another predictor of injury. And so that's why you'll see that a lot of the tests that we do are going to be asymmetrical, meaning we get to look at one side versus the other. So what do we get with movement screening? We're going to watch movement first to understand where weak links exist. All right, and then with that, we're going to learn future injury potential. And in our context, the most important thing is what we don't do. Okay, so if the person can't do an overhead squat, with any competency whatsoever, even after I've made modifications, then I'm probably not going to put a barbell on their back. Okay, if the person cannot stand on one leg in a single leg balance drill, for 5 seconds, I'm probably not going to have them doing a bunch of interval work when they're sprinting. All right, it's just training modifications, and that's going to be the biggest thing with us in our world as personal trainers, is what not to do. And so if you look at the overhead squat, for example, the shape is very similar to that of a golf swing, okay? Because now as I'm squatting down, my back position has to stay flat. I have to be able to sit into my hips. Just as when I'm doing a golf swing, or my athlete is doing a golf swing, he needs to be able to sit into his hips and rotate through his hips in order to hit the ball most accurately. Whereas, over the course of maybe 16 to 18 holes, he's probably he may start to round his back and move from his back more because he gets tired or he just doesn't have access to the proper mobility. This is where we start to see increased injury potential, and this is where pain and issues such as that start to occur. The active straight leg raise is going to be a correlate for deadlifting or picking things up off the ground. All right, so if you have somebody lying on their back in a passive situation where they're getting their heel above a stick, If they can't do that, then the reality is that they probably don't possess the hip mobility or the stability to be able to pull from the floor. That's not to say that I'm not going to do it with that person, but I might have them do rack pulls where, the bar is elevated on blocks or something like that, so they can stand up taller and use the hip range of motion they have available to them. And so when we talk about movement screening, we're going to look at a system of 3, 2, or 1. Okay, 3 is a perfect movement. If they can do it with 3, that means the movement looks great. They do as instructed. I don't need to look at that movement much because I know that they have confidence in there. So that's a green light to train. The 2 is a yellow light, okay, which means that they can do it, but we have to modify the movement in some way. Like, for example, in the overhead squat, the person might not be able to do it just with their heels on the ground, but if I put their heels up on a block, then they can do it because I've taken ankle mobility out of play there to some degree. Okay, in that situation, I would give them a 2, and I would maybe write down ankle because I know that the ankle is something that I want to maybe look a bit closer at. Whereas a 1 is an inability to perform the movement at all. So as far as modifications go, we place a priority on 1s and asymmetries. If the person has any kind of pain at all, okay, and that's more than a 2 out of 10, then we're going to score that person a 0, and we're going to refer them out to our physical therapist or our chiropractor to get them out of pain. Okay, we don't train movements that are painful. That's one of the big takeaways that I want you to get from this presentation. So if the person's doing an overhead squat and it hurts, okay, we're not going to train the squat pattern. So we want to send them out until they can get out of pain, and we can start to retrain that movement. And so with our movement screen, these are the tests that we're going to look at. Overhead squat, single leg squat, toe touch, shoulder mobility, plank, glute bridge, and then I'm also going to say inline lunge. We're going to throw one in. All right. You'll have videos of these. We'll practice these, with you, so you know how to do these. And what I expect is that you're going to do these with a partner, so you know how to do this. It took me probably 50 screens before I fully knew what I was doing and I had a good idea of kind of how things were working. So the more you screen this, the more you're going to be able to see. Okay, and the biggest thing is you don't get too nitpicky over it. Score a 3, a 2, or a 1 or move on, but grade very strictly. Okay, if it looks like a borderline 2 or 1, give them a 1. If it looks like a borderline 3 or 2, give them a 2, even if you don't know what it is. Just write it down and then you can look it up later. But the point is that we just want to make sure that we don't miss anything as we go along here. So as far as our corrective exercise process goes, pretty simple. All right, step 1 is we're going to foam roll. Okay, so in the next presentation we'll look at kind of more about what this stuff means, but the first thing we want to look at is if the person lacks ankle mobility, for example. So in the overhead squat, their arms are over their head and they can't get down all the way, but yet I put their heels up on blocks and then they are. Then I think to myself, okay, so now I'm going to roll maybe the muscles that surround that area so it can get some more mobility there. So I'm standing on a tennis ball, I'm rolling my foot, I'm rolling my hip rotators, the muscles that directly influence that area. Then I'm going to be doing, mobility drills for that area. So in the case of ankle mobility, I'm going to teach the person to drive their knee out over their toe and get a little bit more ankle dorsiflexion. And again, it's not so important that you know what these specific drills are right now, but it's just you follow the thought process of we want to improve the mobility of the area surrounding it through things like foam rolling, and then we're going to try to improve range of motion through these isolated mobility drills. Step 3 would be to modify in some way. Okay, for somebody that doesn't have ankle mobility, I might have them squat down to a box. Okay, so if I know that their knees come over their toes and they're coming forward onto their toes, they have this weight shift forward, then I'm going to have them sit back and sit their butt back onto a box. And the last step, if the person is a 1, is that we substitute. Okay, and so instead of doing deep squats with a person, or even if a box squat hurts, maybe I'm having them do a glute bridge or a hip dominant exercise like a deadlift instead, that fit their current needs a little bit better. Okay, with same thing. So once we work through our movement screen, our next step is fitness testing. And again, fitness testing is simply looking at simple body weight movements to understand how the client moves. Can they do these simple movements? All right. When we look at fitness testing, we're going to look at the push-up, the inverted row, the deadlift, the split squat, the squat. I'm not going to utilize heavy weights or make this very difficult. I just want to see whether the person can move well and has a basic foundation to work with. Can the person do an inverted row? Can they organize their scapula under load in a push-up? Can they pick something up off the ground with a neutral spine, and things of that nature? If they can't do it, then I know that I might need to either regress the exercise, put them on a foundation program, or teach movement before I start to add load to it. So again, fitness testing guidelines, a 3 is perfect form. So I give them the test, they bang it out. I know that they are good to go with that particular movement, which means that they can add load to it. We can make it harder. They're good to go in that area. 2 is going to be performed with some compensation. Okay, so 2 might be a situation where the person can't do a push-up on the floor. The form looks bad, or they can't get down all the way. But then I modify it in some way, meaning I put their hands up on a box or on a Smith machine, and suddenly they're able to do it better because they're not bearing as much weight. In that situation, I could still train that person. I could still increase the load and make it harder. I just need to start them at an easier level. Whereas 1 is an inability to perform the movement. So that means that even if I put their push-up up some, I start them on the ground, they can't do it. I elevate them, they still can't do it. That's a motor control issue. And what that means is the person has just never been exposed to that pattern before. So they just don't know how to do a push-up. So I want to teach a push-up in a very neutral environment that is very easy until they learn the proper form and I start to load that movement. And so in that position, it doesn't matter if I am doing a push-up on the wall with that person. The goal there is not then to gain strength yet. The goal is just to be able to do it. And it's like loading software. I want to train the person's brain to be able to do the movement safely with proper form before I can start to add load to it. Otherwise, I'm starting to build strength on top of a dysfunctional base, which I don't want to do. And so let's use the push-up as an example. A 3 would be 5 push-ups on the floor with perfect form. Okay, a 2 would be they perform the movement well when elevating the hands on a box or a wall. So the focus there would be getting them down to the floor, getting them stronger. A 1 would be they still can't perform the movement, so they need to concentrate on form versus strength. Okay, and you can see sort of the different examples with each one, but using this this graph as a sort of a guideline, this is kind of how we start to figure out, okay, can we start this? Can we start our clients in a pretty aggressive training program, or do we need to start them at a bit more of a foundational level? Also, what patterns can I currently load, and what patterns do I need to teach? And so here are some ideas of how we progress and regress these things. And if we look at an example as far as our a client goes that we might work with, we see Jane Doe here. Okay, and so we see pretty clear priority here. We have a 1 in our single leg balance. And so the single leg balance is the thing that we're going to work on. We might do their correctives as their warm up, and then we're going to substitute certain exercises. So we're going to do split squats rather than step ups. And single leg squats. And so we're making a pretty simple modification to their training program, and then we're just doing the corrective exercise on the front end. So again, not much change, but again, we're just addressing the pattern, improving the pattern, and then putting it back into their program. So for Jane Doe, the other thing is, we see that she squats pretty well and she split squats pretty well. So those are patterns that we could potentially load. Her push-up, though, is just something that she's never done before. So we give her a 1, she can't do it on the floor, and then even when she elevates, it's still deficient, and it's the same way for the deadlift. So for her, instead of loading those patterns, we're teaching her to hip hinge with a stick on her back, and that's how she's deadlifting in the beginning. Keep in mind that we're dealing with a beginner, so anything that we do is going to get a training effect initially over the first, probably 6 to 8 weeks. And so as soon as we can teach her the movement and she can do a body weight, then we can start to progress her and start to add load. Okay, and the push-up is the same thing. We begin the push-up with a static hold to improve their form, and then we start to progress to ball and box and wall push-ups with motion as she gains confidence. And so practical outcomes from this presentation. Number 1, pick one thing to correct at a time. All right, if you see all these things on the screen, we're not looking for We're not trying to correct everything at once. We're just looking for patterns. Okay, what can the person do versus not do right now? And then based upon that, we're going to choose one pattern to work on at a time as far as corrective exercise goes, and we're going to insert corrective exercises for that pattern into the client's warm-up and then as their filler exercises. All right, we're going to substitute heavy loading based upon their risk. And so if the person can't do an overhead squat, they're a 1 there, we're not going to load the squatting pattern. Maybe we're just having them do it assisted, or we're training that pattern, and we're doing more single leg exercises until they can improve that. If you are working with an athlete, we want to adjust their training based upon their screen. So if we find a pitcher with a poor shoulder mobility, maybe you're talking to their baseball coach about or their pitching coach about improving, doing more lower level pitching versus higher volume of pitching. Maybe we're bringing the volume down some. And then what you can do is, as you go along in your cycle, is test and retest the weak links, which means that if I do a full screen and I'm trying to work on one pattern that I found to be a 1, you test and retest that pattern with each session to see whether or not what you're doing is improving the pattern. And if it's not, again, that doesn't mean that it's getting worse. It just means that maybe we put in some different corrective exercises.